I want to thank everyone for joining us here for the webinar, Point of Care Brain Monitoring for the Emergency Medicine, an expert discussion on the world's first point of care monitor. Drs. Diku Mandavia and Lali Garabajian. Dr. Diku Mandavia is the Chief Medical Officer at Ceribell. Being recognized expert in the emergency medicine, Dr. Mandavia brings more than 25 years of clinical experience and nearly 15 years of commercial medical device experience. Dr. Garabajian is an academic emergency physician who completed her fellowship in emergency ultrasound in 2007 at Stanford and remained on at Stanford faculty to serve as the director of emergency ultrasound program and fellowship for 10 years.
I'm really excited about this topic. Non-invasive brain monitoring in the emergency department is such a disruptive new technology, which will really have a profound impact on the care of many, many patients. As an emergency physician, we all get trained in seizure management and status epilepticus. But if you look at most textbooks, that is top of mind for physicians. But in fact, in the critically ill, non-convulsive seizures are very, very prevalent. In fact, in an ICU population, it's about 90%. And this is now increasingly being recognized, and that set of seizures has significant morbidity and mortality. And these are patients that are seen nearly every day in emergency departments across the country. And these patients have a high degree of non-convulsive seizures. So seizures that will be absent to the visible eye. These would be patients that have some form of a neurological disorder primarily, and now have coexistent non-convulsive seizures. So if you think of those patients in status epilepticus, certainly they're extremely high risk. Nearly a half of them will go on to have non-convulsive status. So those would be the patients who would have prolonged postictal periods, et cetera. Those with structural CNS problems on their CT, such as a brain tumor, or ischemic stroke, or hemorrhagic stroke, or traumatic brain injury, they're also very, very high risk. And you can see many of them are double-digit percentage prevalence. So these sorts of numbers and this sort of disease burden is really not that well known in the emergency medicine community and really among a lot of point-of-care clinicians. Other sorts of areas that are also very, very high risk are those with cardiac arrest. I'll be talking about that in the new AHA guideline that just came out last fall. And other sorts of CNS disorders, whether there's infections or even unexplained coma. And we see a lot of those sorts of patients that, we will do full workups such as CT, toxicology. They may even get intubated, but ultimately we're still trying to wonder what's going on. These are patients that are all high risk for non-convulsive status. And if you look at the last decade or so, and this is a graph that shows the number of publications that address non-convulsive status, and you can see a dramatic uptick. And this visibility is certainly known to the neurology community. It's increasingly known to the ICU community, but now relatively new to the emergency medicine community, which sees the exact same sort of patient population. So based on this evidence, so we've had large societies that have stated guidelines to integrate point of care EEG at the bedside. So the Neurocritical Care Society has stated this for seizure activity, and certainly the AHA guideline, class 1 recommendation for patients after cardiac arrest. Is this an emergency department problem? Is this something that an emergency physician should be doing? The answer is an absolute yes. So if you look at time to treatment and efficacy of seizure medications, we see a dramatic drop off after about 2 hours. So the longer the seizures continue, the harder they are to control. So it's really imperative that we recognize and detect them early on arrival in the emergency department, and then to treat them, of course, very, very adequately. But what happens when we don't treat them? Well, if you have prolonged status epilepticus, you're going to have significant morbidity and mortality. And unfortunately, that is still the case in many, many patients because the lack of ready availability of EEG in many, many hospitals. So there may be quite a delay to getting an EEG tech even after they're admitted to the ICU. And so not only do you have significant morbidity and mortality, you have a length of stay, which is very long. So average length of stay of over 16 days and a cost of over $51,000. So it's a significant cost and burden to the health system, and of course, significant detriment to the quality of care when these seizures are not detected early. So, as far as the scope of the problem, it's a pretty significant problem. And there have been some emergency department specific studies showing a prevalence rate of about 5 to 37%, which is very high. So what we're talking about are these patients with altered mental status and a high risk condition. And those patients, now we're recognizing many of these have non-convulsive status. So the concept of coexisting non-convulsive status is really important. You know, as an emergency physician, we may see a patient with a fall, a mild, small subarachnoid hemorrhage, which is a pretty common sort of a presentation, but the elderly patient may be confused and altered. And we often attribute this just to the subarachnoid bleed. But unfortunately, many of these patients, as we know, are very high risk for non-convulsive, and the reason why we should be detecting early. Because we want to avoid not only the morbidity and mortality, we know that there'll be long-term cognitive dysfunction the longer the seizures go on. Unfortunately, the only way to diagnose this is to use EEG technology. And that's been a barrier, largely for the emergency medicine patient. But now, with new Ceribell technology, we have an opportunity to change that significantly. Ceribell is a highly innovative, disruptive technology that they've developed. A primary mission of really improving emergency and ICU care for the neurological patient. They've developed the world's first non-invasive brain monitor, but it's designed for point of care. It's easy to apply with a simple headband, and it provides a rapid clinical answer at the bedside. So frontline clinicians, whether they're in emergency medicine or the ICU, can use this technology and get an answer and try to figure out what to do at the bedside, literally within 5 minutes. So you don't have a very complicated montage with multiple wires requiring a specialized EEG tech. This can be done by a nurse, a regular ED tech as well. And this connects to a recorder. We have a feature called brain stethoscope where you actually can listen to the acoustic sonification of the EEG signals, which you have a very distinctive pattern for seizure activity. But more recently, we have an FDA-approved AI algorithm called Clarity, which can detect seizure activity very accurately. So that's really helpful at the bedside for risk stratification. Furthermore, the device connects to the cloud, and we have a portal which can be read by a neurologist remotely, whether they're on their phone or computer. They don't have to be in a hospital. So let me talk about some of the major indications in the emergency department population. The first one is altered mental status with a high-risk condition. Number 2 is cardiac arrest with return of spontaneous circulation. And the last one is the assessment of the patient with seizures. Altered mental status is a significant problem in the emergency department. And the ED is really tasked with sorting out sick versus not sick, detecting the life-threatening causes, quickly triaging these patients. And a lot of these patients get admitted and have a significant workup. And we do a workup that, of course, includes structural imaging, such as CT or MRI. We'll do lab work, toxicology, et cetera. But we've never been able to do brain function monitoring, which are very high risk. So the conditions that you see here, so whether you have a patient with unexplained altered mental status or those with certainly a history of seizures are very high risk. Any form of a stroke, ischemic or hemorrhagic or subarachnoid, traumatic brain injury, many of you work at trauma centers or even at a non-trauma centers, you see a lot of these sorts of patients. Those with, again, CNS lesions or a recent neurosurgical procedure. Anyone with any form of an encephalopathy, even if it's toxic or metabolic in nature, all of these are very high risk. And lastly, anoxic brain injury. So you can see there's quite a large spectrum of cases, and that's because unfortunately the prevalence is very high among all of these. And we'll have to mention, because all of you know, when we intubate patients and we paralyze them, there's absolutely no clinical assessment. So these are extremely high risk patients that we put on a ventilator, we paralyze them, and we put them in a corner. We should be monitoring those patients. So let's move to the second indication, which is a class 1 recommendation for an American Heart Association, came out in fall of last year, 2020. And that's cardiac arrest with return of spontaneous circulation. These patients have been in cardiac arrest. By default, they've had significant hypoperfusion to their brain. Almost all of these patients have suffered some form of hypoxic insult to the brain. They have hypoxic encephalopathy. That is a very, very high risk condition for non-convulsive status. We know that about 20 to 30% of these patients actually have non-convulsive status. And really, prior to Ceribell, it was quite a complicated procedure to get a full conventional EEG on these patients, especially acutely. Many of you are doing some post-resuscitation order sets. Some of these may include hyperthermic order sets. Many hospitals have integrated now point of care Ceribell technology on these patients because it's really a best practice. Lastly, is the patient with seizures. If they're convulsive seizures, are pretty easy to identify. But again, these patients that go into these prolonged postictal periods, we think they're postictal, but how do we know? We really don't, unless we're doing some sort of EEG monitoring. Also, the patient that we're doing active medication titration. With the Ceribell technology, we actually have an ability to look at seizure burden. You can actually see seizures as they're increasing in frequency or they're decreasing. So you can actually adjust medication using the Ceribell technology. And lastly, another population which most emergency physicians will also resonate with is suspected pseudoseizure. Right? These are patients that do show up in the ED. There is, as you know, a Venn diagram overlap with those with true seizures as well. So they can be diagnostically quite complex, and having another data point is really valuable when you evaluate them. Lastly, I'm going to mention this is a technology that's actually been validated in a multi-center trial at multiple hospitals throughout the country, over 180 patients, nearly 40 ICU patients. And what they recognize is that diagnostic accuracy and diagnostic confidence both improve significantly with point of care EEG data. In emergency medicine, especially, what we do is a lot about risk stratification. We do more decision-making with the least amount of data. So in these conditions, typically the answer would be zero data, right? We're working on a clinical suspicion, but the ability to have EEG technology and give you another data point is substantial, and this is proven out in this study.
Now that I'll describe the experience that we have at Stanford, I do want to disclose that we were part of a multi-center research study that has been published. You know, we know the clinical trials and studies that go on in our emergency department, and it really allows us to more easily adopt new technology that has proven to be successful and effective and impactful. This particular study, it was a small prospective study. There were about 38 patients, multi-center, and 20 of them had a change in management, largely because the physician thought a seizure was happening, but it actually was not. And so they avoided anti-epileptic medication. There was one case of non-convulsive status that was not clinically apparent, that the physician did not think was going on, and Ceribell was able to identify it. So the other important thing was that 8 out of these 38 patients had a more rapid disposition because of Ceribell and what we found out with Ceribell. And that's important for emergency department operations. But what I focus on, being the medical director and quality director, is the patients and how technology impacts the patients and the ease of which that technology can be functionalized. And thankfully, this one was really easy. So because we started with this study, then we were eager to see when it goes into commercial market to be able to see how it can close some gaps. We are a level 1 trauma center. We are a STEMI and stroke receiving center. We see about 80,000 patients per year. And we have a pretty robust and extensive case and quality review group that I lead, where cases come to our attention for review, either self-referral from our own physicians or from other services, to see what we can learn from them and to try to prevent things in the future. So We have a patient population where indications for assessing non-convulsive status epilepticus exists, and we knew there were gaps that we needed to close. There was one case in particular right after the research study and before we had Ceribell that is etched in my mind. This was a 50-year-old who had a history of traumatic brain injury and who also had a history of seizures, was on prophylactic antiepileptics, who had a food impaction and needed a bedside GI removal, endoscopic removal. The first emergency physician at the very end of their shift received this patient right before their sign out, evaluated the patient. The patient did not have, a normal neurologic baseline, had, some cognitive disability and although was able to converse and verbalize needs and complaints well. Then the second physician came on shift, and now it's an overnight shift. And the GI folks came in several hours later in the middle of their shift. The GI folks had done the procedure, sedated the patient, and then the patient was in recovery. And at the end of that second attending's shift, they went to evaluate about an hour post sedation, an hour post procedure. And the patient was a little hypertensive, slightly tachycardic. It was in the middle of the night, was seemingly groggy, and was poorly responsive, yet would move and say no. And so thought, it's in the middle of the night and they must be really sleepy. Let's just have him sleep until the morning. And so then the third physician comes on early in the morning, reassesses and sees that, something is not right. This is several hours now, not waking up well. I'm the third attending. I don't know how this patient came in who has a history of traumatic brain injury. And so they called a stroke code because the patient had some unilateral findings that were pretty mild, actually. Head CT was negative, admitted to medicine with the stroke team following. They did an EEG later that afternoon, which now we're going on almost 24 hours now. And the EEG showed, not Ceribell, but the EEG from the EEG lab showed non-convulsive status. This patient had the teams had a very difficult time controlling their status. And the patient had a prolonged stay, had to go into the ICU, get on drips and come back because of how difficult it was to control their status. And those of us who knew of the study with Ceribell prior to this, it was pretty jarring for everyone. The emergency physicians, of course, just felt like, I should have known. How could I have not known? But non-convulsive status, it is a very difficult diagnosis to make in our emergency department. There can be various factors where anchoring can happen. And so this case for me was really etched in my mind. It's the one I share with everyone because this could have easily been picked up by Ceribell on that second attending an hour after procedural sedation and had a more better time in managing their non-convulsive status. So, there were some other cases now that we had, and it really then allowed us to understand the impact of Ceribell, one of which was an 80-year-old with a history of metastatic cancer to the brain. They were altered, they were in a delirium. They were found hyponatremic with an acute kidney injury and bacteria, and so they were admitted to medicine, thinking that those were the etiologies of that altered mental status and delirium, with a head CT that didn't show any new or acute findings. Despite the correction, after admitted, the altered mental status persisted. Neurology was consulted, again, an EEG was obtained, and that showed the patient was in non-convulsive status too. Just another case of, what I consider a delay in diagnosis for a very, very difficult condition. After doing that research study, we then are wanting to close that gap, especially if there's a technology that's able to do that for us, that we know very well, that we know is easy to interpret and implement. And so then we got Ceribell once it became available, and then the education and implementation started. It started with in-servicing our ED techs, which didn't take very long at all. It's a very easy device to put around and to teach our techs how to do. I think it was a 15 or 30-minute in-service that we did in various groups. Then we trained our nurses as well regarding the technology. And then our physicians, which really involved video training and listening to cases through the brain stethoscope of that training video to know what a seizure sounds like and what it doesn't sound like. And then go into that early adoption phase where people then need to now just simply remember that we now have Ceribell, so you can order it, which I think is the biggest obstacle we're going through now. We developed a workflow. Essentially, we put an order in the EMR, which then automatically nudges the EEG fellow that's on call that there is a Ceribell read that's going to come to their attention within the hour. The tech puts it in, they notify the physician. We listen with the brain stethoscope immediately upon the implementation of that device around the patient's head. We listen for any non-convulsive status activity. If there's any issue or confusion, we wait the 5 minutes for clarity to give us confirmatory findings. We match that with our clinical suspicion, and then we decide what to do next within the EEG fellow giving us those results within 30 minutes to an hour. But in our experience, we haven't really needed that EEG fellow's result because it's so obvious, and so far Ceribell has not proven us wrong. It's been right every single time that we've used it. So after Ceribell, we started to see more cases and we started appreciating really what this device has done for our patient population. There was a patient who was a stroke code activation, who had obvious unilateral findings, thought very convincingly that this was a stroke. Head CT was negative, the stroke team was involved. MRI was ordered as per our protocol, but Ceribell was then placed. And it was found that this patient had non-convulsive status. This, because we are, the way our stroke code activations work, this was maybe about 15 minutes after arrival that we were able to diagnose non-convulsive status. And counter that to the patient who is etched in my memory where it was almost a day. This patient was more easily managed and treated for their non-convulsive status because of this early diagnosis. Then we had a patient who was 40 years old, had a history of seizure on anti-epileptics, came in poorly verbal, really drowsy, had twitching. The physician team thought for sure this patient was having a seizure, a breakthrough seizure through anti-epileptics, wanted to get anti-epileptics on board, had Ceribell immediately placed, and this Ceribell was negative. Neurology was consulted, and then they switched it. They kept the Ceribell on because it can continue to monitor. And imaging was done, and the patient was actually found to be toxic on lithium. And we didn't add to that burden with anti-epileptics. We avoided managing any kind of seizure activity, and then we were able to get our poison control and specialists on board to actually manage this patient for what they actually needed. We whenever there is new workflows, new technologies, any real saves, we always highlight it in our group. And so when we had this, of course, people started talking about the various cases. And now what we're going through after adopting Ceribell in just these last couple months is we're going through those cases, and we're being quite critical of how Ceribell was used. Was it easy to order? Was there any breakthrough or pitfall in the workflow that we've developed, and try to optimize that? We did integrate it into the EMR, and we're looking to see how we need to integrate that more, such that the standard of practice for the high risk and obvious indications for Ceribell have that part of pathways in the future. And we recently did a data review of the last 5 months to see what were the indications for Ceribell, what did we pick up, and what were the ultimate diagnoses that occurred. And what we found was we likely should project that we should be using Ceribell about 50 times per month. And the indications for those are strokes that require admission, traumatic brain injury requiring admission, altered mental status with an ICU admit. So they're truly critically ill, altered mental status patients, seizures that require admission, and of course, ROSC post-arrest. And those with our patient population, it's projected that we are likely going to be using this at a minimum of 50 times per month.
As an ER doctor, listening to those cases, every one of those cases, they're like M&M cases. None of those cases are really like abnormal cases, right? They're like everyday cases that ER doctors are dealing with this problem. So tell me about your other colleagues. What do they think about Ceribell, given now these cases and things like this?
They are eager to use it because they understand its effect and impact and the data that they can obtain from it quite easily and quite quickly and quite accurately. So many of them who know that we have it, are believers in it, they want it right away. And that's how it should be, focused on the chief complaint and the presenting signs and symptoms, and then screening for non-convulsive status. I'm actually surprised, just because of my experience with point of care ultrasound, where it takes quite a bit of time for early adoption. And I think the reason for that is because we did the study at Stanford, and we publicized about it, we talked about it, and we showed the data of its accuracy and the training and just how easy it is to listen and hear non-convulsive status. I think that helped eliminate that obstacle or that fear that was present with point of care ultrasound.
One of the questions that I always get is like, how much training is required? If you look at the other disruptive technologies, it takes a while to learn and change a care pathway. So I know you trained, obviously, your techs, your nurses, your doctors. What was the receptivity, especially of the nurses and the techs, of learning this technology, and how much of a burden was it for them?
When we first started the research study, it was assumed it would be incredibly difficult. And I think there was that fear of, is this in my scope or not? Am I allowed to do this, when it came to techs and nurses? And once that hurdle came through, where that was then understood that it was in their scope, they can put on the device, there was support for them. And then the in-service actually was pretty easy, because once they were shown how to do it, the first response, I think, was, oh, that's it. That's all it is. We just wrap this around the head and then press a button. And then because of that, then the nurse managers who are in charge of the techs, when it was time for Ceribell to actually get implemented into our clinical practice, then they were quite on board with teaching the new group of techs that we had hired. And they knew that it was quite easy to perform and quite easy to teach. And I think the toughest ones were not the techs or the nurses, but it was actually the physicians, to have them listen to, I think it's a 10-minute video on Ceribell and the brain stethoscope, and hear case after case after case of what's not non-convulsive and what is non-convulsive status. The response I get from the physicians are, that seems too easy. It's easier than an EKG. You have clarity that in 5 minutes will let you know whether what you're hearing is right, and you can wait that 5 minutes. Or you have your EEG fellow who's going to read it within the hour, and you do what you think is best for the patient. Don't sacrifice patient safety or patient care due to any obstacle that you're having with this. And all the feedback that I'm getting right now is that it's very easy, and because it's easy, they want it right away, right after evaluation. And more physicians are feeling that way.
It's interesting you mentioned about the nursing component. As you know, nurses really own physiological monitoring in the ER or the ICU. And that case that you described that had sedation, deep sedation, and I would bet you had full physiological monitoring for that patient, but without brain monitoring, right? So think about that as we look into the future. Would a case like that, who would have had brain monitoring right from the get-go for a deep sedation?
I think so. I mean, he checked all the boxes, history of traumatic brain injury, history of seizure, who wasn't appropriately taking anti-epileptics because he had a food impaction, so subtherapeutic on that preventive management. And so why not put a Ceribell device from the very beginning such that we can identify if the patient is going into a non-convulsive status when it's not clinically apparent? He had all the monitors that procedural sedation requires. The only thing was that he was mildly hypertensive, which he had a history of hypertension. His heart rate was hovering between 90 to 110. Which was unclear as to why, and it was probably the non-convulsive status. Otherwise, there was no twitching. He would answer questions in just 2 to 3 words. He seemed groggy and drowsy. It was in the middle of the night. Any of us could have been in that position to anchor on what the environment and surroundings and not think of non-convulsive status. That patient who had a stroke, or stroke-like symptoms, I should say, with that CT head was negative and Ceribell was positive, TPA was going to be given to that patient. But because that patient's Ceribell was positive, they stopped that and they got an emergent MRI that happened within 30 minutes, and it was actually a brain mass. It wasn't a stroke. So imagine if you're giving a TPA to a brain mass, the risk of bleeding. I mean, it's these cases that keep coming at my desk, and for review, this device is worth it to have an RED.
If you're having a stroke and you have altered mental status, why would you not put a Ceribell on?
There's no reasons. I think, this is part of what we do in emergency medicine. We evaluate, we get all the data that we can in order to have us have a more accurate diagnosis and thus a more accurate management. And the quicker we can get that information, the better. So, we do our history, we do our exam, we get an EKG at times, we do point of care ultrasound to screen for critical illness. And if there's something that is neurologic in their signs or symptoms, altered mental status where the patient can't provide us a history and we don't understand the reasoning for it, especially if they're critically ill, put Ceribell on. If they are having stroke-like symptoms, put Ceribell on. If right after cardiac arrest and post-ROSC, put Ceribell. What we can do as a specialty in emergency medicine to have that early diagnosis and thus a better outcome for these patients because they are better able to be managed for their non-convulsive status. I mean, it makes just total sense.
Where do you see the future of traumatic brain injury and Ceribell?
I think that when there's a trauma activation and a patient is altered with a mechanism of injury that we're concerned that the patient may have a traumatic brain injury, I think the Ceribell device is going to be placed on right away. Even if the CT head is negative, there's a use for Ceribell because we don't know what the circumstances were for many of these patients that who came in as trauma activations, especially the single vehicle motor vehicle accidents, people who were found down, especially those who seem to be intoxicated or appear intoxicated or in some sort of withdrawal and they're found down, but they come in as trauma activations. I see Ceribell going on their heads very early on to screen for non-convulsive status.
Right now, the standard of care for syncope in a high-risk patient is admission for cardiac monitoring, but we don't do neurological monitoring. We don't do any EEG monitoring for the seizure part. Do you think there's opportunities at changing those sort of care pathways where we think about this a little bit more?
I think yes, especially if the patient's altered. If there is some neurologic sign or symptom for a patient that you thought had a syncopal event, that's absolutely an indication for Ceribell.
Yeah, and thank you everyone for attending today. And if you have additional questions or you'd like more information about this topic or Ceribell in general, please don't hesitate to contact us directly on email at eeg@ceribell.com. Thank you everyone for attending.